Estrogens were recognized 5 decades ago as the main risk factor for developing breast cancer. However, their assessment has been relatively limited to a traditional exposure analysis that is based on menstrual and reproductive factors and family history of cancer. Currently, the importance of other risk factors different from such classic ones is somehow underestimated. Something similar happens with the idea of breast cancer prevention. We must take into account that breast cancer is a multifactorial disease for which lifestyle plays a key role. We need to recognize that breast cancer prevention is currently focused on the mammogram, which is the tool towards an early diagnosis. Early detection is currently accepted as the main instrument against mortality due to breast cancer, since it allows better results of therapies. In my opinion, the concept of breast cancer prevention has been stuck in this position. Early detection is part of what is known as secondary prevention. It has achieved an impact on mortality, but not in incidence, that is, in the morbidity of the disease. Where mammograms are periodically performed to women, breast cancer mortality has tended to decrease. On the other side, the disease does not show any significant trend suggesting us that it is less frequent. Besides, emerging countries are watching since some years how breast cancer is now at the top of their cancers ranking, just as the same as developed countries have experienced it in the past. Nevertheless, it would be positive to recognize that breast cancer is an essentially preventable tumor through the different ways that prevention can be developed. In this sense, primary prevention attempts to reduce incidence through a reduction in the exposure to risk factors and/or through an increase in exposure to protective factors. The attributable risks related to breast cancer can be summarized as follows. A responsibility of 5% and no more than 15% of all cases is recognized for the family history of cancer. A high-risk family history based on certain demonstrated gene mutations accounts for between 2 and 5% of all cases. Menstrual and reproductive factors like early menarche, nulliparity, late first delivery, short breastfeeding time, late menopause as major factors are thought to account for 25% of the cases of breast cancer. Considered together, these classic factors explain between 30 and 40% of the incidence. The rest are mostly environmental modifiable factors, and they correspond to a 60 to 70%. In other words, of each 100 women with breast cancer, 60 or 70 have not any of those called classic risk factors, but they develop a cancer anyway. Of the environmental and modifiable factors, diet is considered the most important one. It is accepted that a risk reduction through influencing dietary factors can reach a 30 to 35% of the whole risk. The rest of factors include excess weight and obesity, metabolic factors, for example, insulin resistance, low serum vitamin D level, dyslipidemia, diabetes, low level of physical activity, and psychosocial stress, among other possible factors. As we said before, previous research on classic risk factors enabled us to know that women who have been exposed for a longer time period or more intensely to endogenous estrogens will have an increased risk of breast cancer. However, scientific research has also demonstrated that diet, fat excess, and a low level of physical activity can also strongly affect the hormonal production and availability, independently from having or not any of the quoted classic risk factors. In my opinion, the ultimate goal of the strategy should be to achieve a hormonal and metabolic modulation through nutritional factors, which are the ones playing a major role within lifestyle. If we are strict about the concept of prevention, we could find mammograms more as diagnostic tools than as preventive instruments. Reducing only breast cancer mortality as an example of prevention of a cancer is like having a one-eye vision of the problem. Accepting that a preventive strategy for breast cancer is covered only by having periodical medical consultations and mammograms seems inadequate. On the contrary, achieving an impact on the nutritional field means doing something else for breast health than early detection. A primary prevention strategy added to secondary prevention will allow for even better results, not only in reducing mortality, but also contributing to a reduction in incidence. This would be like a stereoscopic vision of the problem. Both primary and secondary prevention strategies do not exclude each other. There are several challenges, for example behavioral, to be faced in order to achieve the success of such nutritional prevention. We support the idea of an intervention strategy for breast health promotion, but having the condition that is culturally appropriate for a specific population. What we are proposing to do in primary prevention is mainly a quantitative and qualitative change in the bioavailability of an exposure to the own estrogens. In other words, to manage fewer and better hormones. It is medically and ethically justified to recommend some nutritional changes to patients and to healthy women. This would constitute at least an attempt at low-cost intervention without adverse side effects, contrary to those one can expect from drug treatments. While there is no clear evidence that any specific dietary component can effectively reduce breast cancer risk, the fact that several measures have convergence on the control of amount and quality of estrogens is something we can profit from. Thank you for your attention.